This video demonstrates a combined transarterial and transvenous approach for embolization of an anterior skull-base arteriovenous fistula. This is the case of a 49-year-old man who presented to the emergency department with seizures. The patient was on aspirin and prasugrel due to recent cardiac stenting for his coronary artery disease. Non-invasive imaging demonstrated a possible left frontal AV fistula. A non-contrast CT was unremarkable. These MR images demonstrate a likely draining vein as well as hypervascularity within the anterior skull base region in the gyrus rectus. The patient desired treatment for his AV fistula, but given the patient's aspirin and prasugrel, microsurgical excision was contraindicated. It was therefore decided to proceed with endovascular embolization. AP and lateral views from a left internal carotid artery injection demonstrate the fistula with ophthalmic artery feeders and early drainage into the superior sagittal sinus. This magnified view again demonstrates the ophthalmic artery feeders as well as early draining veins. Using this high mag view as road map guidance, we were able to obtain access using a microwire microcatheter system. Once the microwire is brought into the region of the intracranial portion of the internal carotid artery, it is redirected in order to obtain access to the ophthalmic artery. We proceed with microwire pushed in J fashion to obtain access to the distal ophthalmic artery. The microcatheter is advanced in conjunction with the wire in order to obtain distal access. We obtain another road map view in order to navigate the turn at the distal portion of the ophthalmic artery. We proceed by pushing the jade wire until we are almost within the fistula, at which point we reduce the J and introduce a straight wire in order to obtain access to the fistula itself. At this point, a second microwire microcatheter system is introduced through the guiding catheter. This is advanced again into the anterior skull base, whereupon we are able to obtain access to the ophthalmic artery in identical fashion as we did before. We'll use a dual microcatheter system in order to both embolize using liquid embolic as well as coil in order to safely obliterate the fistula without putting the parent vessel at excess risk. We proceed again by advancing the microwire into the fistulous area, and then we advance our coiling catheter to within the region of the fistula. The microcatheter is now demonstrated to be within the fistula. At this point, we can begin to introduce coils. The second catheter is again our coiling catheter, and through it we will begin to deploy coils within the parent artery. The goal here is to create a plug that will prevent reflux of the liquid embolic agent as well as to occlude flow into the fistula itself. We push several coils into the area of the fistula, but beyond the region that subserves normal structures. Once we are satisfied with the coil plug, we are able to proceed with stage 2, which is utilization of onyx liquid embolic material for complete occlusion of the fistula. Using pulsed flow, we begin to flow liquid embolic agent into the region of the fistula. We desire to completely fill out the fistula sac in order to occlude it. One issue when treating fistulas through a transarterial route is there may be multiple arterial feeders that coalesce upon a single venous outflow, and occluding all of these relies upon occlusion of the venous sac in order to completely obliterate the fistula. We see here that onyx continues to flow into the venous sac, creating a sizable plug within the fistula. Follow-up run through the left external demonstrates persistent flow through collaterals into the fistula. This high magnification view again underscores the essential problem of having multiple arterial feeders feeding into a single venous drainage. At this point, we opt to proceed with a transvenous approach for embolization of the fistula. We obtain left femoral vein access and advance up through the venous anatomy. We advance from IVC to SVC up into the jugular, around the sigmoid, and into the transverse sinus. Once we've obtained access to the transverse sinus, we want to obtain access to the superior sagittal sinus. We advance our catheter into this region and then are able to push our wire even more distal across the top of the superior sagittal sinus in order to obtain access to the anterior skull base. Once we have access to the anterior skull base, we again obtain an angiogram in order to serve as roadmap for future navigation. Our wire is then able to feed into the fistula's draining vein. This now allows us access to the venous pouch, whereupon we can successfully deploy our liquid embolic agent to occlude the fistula. We withdraw the wire, leaving the catheter in place, and begin again using pulsed flow to flow the liquid embolic agent into the region of the fistula's pouch. We can see that the onyx begins to flow into several of the venous channels, not only within the pouch, but out into the surrounding veins. We continue to fill out this venous pouch until we feel that we have complete obliteration of the fistula. In general, venous obliteration in the anterior skull base region is well tolerated and the patients are able to have a good recovery. We see on follow-up angiography that the fistula is completely obliterated with no sign of filling of the draining veins. Furthermore, the arterial component is also no longer visualized.